To Dr. Ignacio School's medical tutorial, and today we'll be talking about Kala-azar, also known as visceral leishmaniasis. So let's go. So from this presentation we will learn about the epidemiology, the transmission, the life cycle of leishmania, the clinical features, the investigation, the treatment of Kala-azar, and the management of post-Kala-azar dermal leishmaniasis. This is the example of a case of Kala-azar, and this is the splenic aspirus showing the leishmania Donovan bodies. Leishmaniasis occur in approximately 100 countries around the world, with an estimated annual incidence of 0.9 to 1.3 million cases, new cases, out of which 25% are visceral leishmaniasis or Kala-azar. So visceral leishmaniasis is caused by the protozoan Leishmania donovani complex, comprising Leishmania donovani, Leishmania infantum, and Leishmania chagassi. India, Sudan, Bangladesh, and Brazil account for 90% of the cases of visceral leishmaniasis. This chart showing the world distribution of visceral leishmaniasis and the strains that are present. In India and some part of Africa, Leishmania donovani is the causative agent. In some part of India and part of Europe and Russia, Leishmania infantum is responsible, and in the Southern American region and Brazil, Leishmania chagassi is involved. So talking about the transmission, there are three modalities of transmission basically. The zoonotic visceral leishmaniasis or cutaneous leishmaniasis caused by Leishmania infantum, Leishmania major, Leishmania brasiliensis, Leishmania mexicana. The host is human, but the source or reservoir of infection is the dogs. There is a zoonotic transmission. And in the cases of Leishmania donovani, which occurs predominantly in India, there is no animal reservoir. For Leishmania tropica also, there is no animal reservoir. The transmission is from human to human by sandfly. Another important modality of transmission in Leishmania infantum is the anthroponotic in injection drug use, the sharing of needles. So what about the transmission? So all the most clinical syndromes are caused by zoonotic transmission of parasite from animals, chiefly canine and rodent reservoirs, to human through phlebotomine sandfly vectors. Humans are the only known reservoirs in major visceral leishmaniasis foci in the Indian subcontinent and injection drug uses. So the life cycle of Leishmania parasite. The flagella promastigotes 10 to 20 micrometer are introduced by the feeding female sandfly. The promastigotes are taken up by the neutrophils. The neutrophil will ingest the promastigotes and then undergo apoptosis. The neutrophils will die, and the promastigotes thus released are engulfed by the macrophages. And in these macrophages, the parasites will transform from promastigote into the amastigote, that is the Leishman Donovan bodies, and they will multiply, causing macrophage lysis, and will infect other cells, and sandfly will pick up the amastigote when feeding on the infected patient or animal reservoirs. In the sandfly, the parasite transforms into the flagellar promastigote, which multiplies by binary fission in the gut of the vector and migrates to the proboscis to infect the new host. So whatever I said is given here. The sandfly will inject the promastigote. The promastigote will develop into amastigote. The promastigote is ingested by the neutrophil. The neutrophil will undergo apoptosis, and the macrophage will ingest the promastigote. Inside the macrophage, it will develop into Leishmania Donovan bodies and into amastigote, and the amastigotes are released, and the amastigote are taken by the sandfly, and thus the transmission occurs. So what about the sandfly? These are the sandfly, the Flavosomus species. Zooming in, let's zoom in a little bit more. So this is the sandfly. The clinical features. The fever is a major clinical feature. The first sign of infection is high fever, usually accompanied by rigor and chills. Fever intensity decreases over time, and the patient may become afebrile for intervening periods ranging from weeks to months. This is followed by relapse of fever, often of lesser intensity. So initially there is high fever with chills and rigor, then the patient becomes afebrile, and there is again relapse. So the clinical features are splenomegaly, which may be massive, moderate hepatomegaly, lymphadenopathy, which is rare in the Indian subcontinent, the blackish discoloration of the skin, by which it gets its name Kala-azar. Kala means black, the moderate or severe anemia, thrombocytopenia, and bleeding from the retained gastrointestinal tract and nose because of thrombocytopenia and the accompanying liver failure. So other clinical features are hypoalbuminemia, which may manifest as pedal edema, ascites, and anasarca. There is gross generalized edema and swelling. There can be pedal edema, ascites, and even anasarca, and profound immunosuppression and secondary infections are very common. So what are the investigations we do? Pancytopenia is the dominant feature, so there is anemia, neutropenia, and decrease in the platelet counts, along with granulocytopenia and monocytosis. There is polyclonal hypergammaglobulinemia, that means IgG and followed by IgM increases. There is reversal of albumin to globulin ratio. There is hypoalbuminemia, and we can demonstrate mastigotes or the Leishman-Donovan bodies in splenic smears. This is the most efficient means of diagnosis with 98% sensitivity. However, it carries a risk of serious hemorrhage in inexperienced hands. So, a splenic smear is 98% sensitive, but there is a risk of splenic hemorrhage. And bone marrow or lymph node smears can be done. They are alternative to splenic smear. We can do PCR for DNA detection and species identification. We can also do serodiagnosis by ELISA or immunofluorescence antibody test. There is also direct agglutination test. And another one commonly used instant test is the rapid immunochromatographic K39 test or the RK39 strip test. So this is the splenic smear showing numerous intracellular and a few extracellular mastigotes. So about the management of visceral leishmaniasis or Kala-azar, there are the pentavalent antimonials, which are the sodium stibogluconate, Amphotericin B, the oral drug Miltefosine, paramomycin, and pentamidine isethionate, which has been abandoned due to severe side effects. So the pentavalent antimonials are the mainstay of treatment in most part of the world. The exception is the Indian subcontinent, especially the Bihar state, where almost 2/3 of cases are refractory to antimony treatment. Traditionally, pentavalent antimony is available as sodium stibogluconate 100 mg per ml in English-speaking countries and meglumine antimoniate or 85 mg per ml in French-speaking ones. So it's called sodium stibogluconate or meglumine antimoniate. The daily dose is 20 mg per kg body weight intravenously or intramuscularly for 28 to 30 days. So the side effects of pentavalent antimonials include arthralgia, myalgia, raised hepatic transaminases, pancreatitis, especially in patients co-infected with HIV. ECG changes include T-wave inversion and reduced amplitude. Severe cardiotoxicity manifested by concave ST segment elevation, prolongation of QTc greater than 0.5 millisecond, and ventricular dysrhythmia. They can also be present. And the incidence of cardiotoxicity and death is particularly high with improperly manufactured antimonials. Amphotericin B, the antifungal drug. The antifungal amphotericin B deoxycholate given once daily or on alternate days at a dose of 1 mg per kg for 15 to 20 days is used as a first-line drug in many regions where there is significant level of antimony unresponsiveness. So if there is resistance to the antimonial compound sodium stibogluconate, we can give amphotericin B. It has a cure rate of nearly 100%, and there is infusion-related side effects such as high fever with rigor, thrombophlebitis, diarrhea, and vomiting. These are extremely common, and serious side effects like renal or hepatic toxicity, hypokalemia, and thrombocytopenia are observed frequently. So to decrease the side effects of amphotericin B, we can give liposomal amphotericin B, which is less toxic. It is given as a liposomal formation. A total dose of 10 or 15 mg per kg is administered in a single dose or in multiple doses over several days, respectively. This is considered to be adequate. So the only oral drug is Miltefosine, a daily dose of 50 mg for the patient's weight less than 25 kg. So patients less than 25 kg, we give 50 mg dose, and to patients more than 25 kg, we give 100 mg dose, and we give 2.5 mg per kg dose for children. We give this dose for 28 days, and this cures the disease in over 90% of patients. Side effects can include mild to moderate vomiting and diarrhea, and rarely skin allergy, renal or liver toxicity. Since miltefosine is a teratogenic drug, it cannot be used in pregnancy. About paromomycin. Paromomycin is an aminoglycoside that has undergone trials in India and Africa, and this is highly effective if given intramuscularly at 11 mg per kg of paromomycin base daily for 3 weeks. No significant auditory or renal toxicity, which is a side effect of aminoglycoside, is seen, so significant side effects are not present. What about post-Kala-azar dermal leishmaniasis? After treatment and apparent recovery from visceral leishmaniasis in India and Sudan, some patients will develop dermatological manifestation due to local parasitic infestation. So they are seen as macules, papules, nodules. Most frequently they are nodules and plaques, which have a predilection for the face, especially the area around the chin. The face also appears erythematous. PKDL patients are human reservoir of infection. And sodium stevogluconate for 120 days, or several courses of Amphotericin B infusions, or miltefosine for 12 weeks is the treatment for PKDL. So treatment is similar but for longer period. This is an example of a case of PKDL: macules, papule and nodules. In Sudan, they may present as micronodular rash. Thank you. Please subscribe to my channel. This has been Ignatius Cole.